Hello, everyone. Thanks for joining the webinar today. Today I'm going to be talking about platelet lysate. Platelet lysate is the newest orthobiologic that we're offering here at San Diego Orthobiologics. So first, I'm going to review platelets and PRP that most of you know about. First, platelets are the first responders to an injury. They're the tiny cells in the blood that respond to an injury. They get activated in response to an injury. As most of you know, they aggregate to stop bleeding and they form a clot, and then they also secrete numerous growth factors. You can see in the video here, these platelets going to the site of the injury, they aggregate and start secreting growth factors to initiate that healing process. So what is PRP, or platelet-rich plasma? That's where we take a sample of your blood and we concentrate the platelets out of that blood sample using a centrifuge. So that centrifuge process will separate the different cell layers based on the weight of the cells. So after the centrifuge process, the heaviest cells, which are the red cells, go down to the bottom. The middle white layer is the concentrated layer of platelets, concentrated platelets. And then the top layer is the liquid portion of the blood called plasma. So if we take that concentrated platelet layer plus some plasma, we have platelet-rich plasma, or PRP. Now, as most of you know, PRP is used extensively in orthopedics to treat various conditions, including joint arthritis. It's used to help heal chronic tendon or ligament injuries, such as tennis elbow, rotator cuff tendon injuries in the shoulder, patella tendon injuries, gluteal tendinopathy. It's used for plantar fasciitis, as well as adhesive capsulitis, or frozen shoulder. And there are numerous level 1 high-quality randomized controlled trials showing that PRP can be effective for treating all these conditions. I'm just going to review some of the more recent data that we have on PRP. This is a systematic review and meta-analyses of 18 different randomized controlled trials, which evaluated different injection therapies for carpal tunnel syndrome. The authors found that PRP is effective for treating carpal tunnel syndrome in both short-term as well as long-term, whereas steroids were only effective in the short-term. So these authors concluded, it was their opinion, that PRP should be used as a first-line treatment for carpal tunnel syndrome. And this study was published in May of 2024. This is a study published in April of 2023, looking at patients with lumbar disc herniation. It was a randomized controlled trial where they treated half of the patients in the group with PRP epidural. So they injected PRP into the epidural space around that herniated disc, and half the patients were treated with a typical standard epidural steroid injection, so injecting steroid into the epidural space around the herniated disc. Only 30 patients, but this did show that both groups saw improvement, but the PRP group showed statistically better reduction in leg pain compared to the steroid group at 6, 12, and 24 weeks. Here's another study published in May of 2023, again looking at the use of PRP versus steroid for lumbar radiculopathy due to a herniated disc. This was a larger study, 60 patients. Again, half received PRP epidural injection and half received a standard steroid epidural injection. And this study showed that both groups had statistically significant improvement at 1 month and 3 months. Now, the steroid group was actually better at 1 month, but the groups were equal as far as improvement at 3 months. But only the PRP group had sustained improvement at 6 months. So this is a common theme that we see in a lot of these studies which compare PRP to steroid. Steroid can help, definitely, but is more short-term, whereas PRP is going to give you a longer-term, more sustained, better outcome. And most of you know that a lot of athletes, professional athletes, have been using PRP for years to help enhance injury healing. So what is a platelet lysate? So platelet lysate is a variation of PRP where we produce PRP and then further process the PRP to lyse the platelets and release all the growth factors from those platelets. So in PRP, we're taking those concentrated platelet cells and injecting that into the site of the injury with PRP. And when those platelets get injected, they start to slowly activate and release the growth factors over time in a matter of hours to days. Whereas with platelet lysate, we're taking the PRP and lysing those platelets to release the growth factors. And then the injectate that we have is very acellular. There's little to no cells in platelet lysate. We're just injecting a growth factor rich solution. So how do we make the platelet lysate? So there are different methods that we can use to lyse the platelets and produce the platelet lysate. One, the most common is probably the freeze-thaw method. Second is ultrasound bath. And third is ultrasound probe. I've also seen ozone used, but these are the three most common methods used to produce platelet lysate. In our clinic, we've adopted the freeze-thaw method. I did a lot of research, and this was definitely the most common way to produce PRP. So basically, we make our PRP like usual in our clinic. So we draw the blood, concentrate the platelets, and we have our PRP. And then we take the PRP and we freeze it in this medical grade freezer at -80 degrees. And then we thaw that frozen PRP. And then we do a freeze thaw of 3 cycles. They found that 3 cycles gives you the optimal release of growth factors and cell lysis. So we do 3 cycles of the freeze thaw. And then we do a final centrifuge to remove all the cell membrane debris, and another final filtration with a filter to remove debris. And we're left with platelet lysate. And we've tested this numerous times. We've been using it in the clinic now for about 2 or 3 months now. And we have been testing it and confirming that we're getting greater than 99% cell lysis using this protocol. And we confirmed this with our cell counter that we have in the clinic. So we check the PRP and count the number of cells that we have, the number of platelets, and then we produce our platelet lysate and recheck that in the cell counter, and we're confirming greater than 99% cell lysis using this protocol very consistently. This is an example of platelet lysate and PRP next together. A patient I did yesterday, we injected PRP into the spinal ligaments and joints, and then I put the platelet lysate into the epidural space around the nerves. The syringe on the right is the PRP, the platelet-rich plasma. You can see how it's a little more turbid and cloudy looking, because that sample has approximately 10 billion platelets in there. And then the platelet lysate is the syringe on the left. You can see it's much more clear, very acellular, confirmed greater than 99% cell lysis. So that's what platelet lysate looks like. No cells, just pure growth factors. So where do we use platelet lysate versus PRP? What are the potential advantages to use platelet lysate? One advantage is that platelet lysate definitely has more of an immediate anti-inflammatory effect, whereas PRP initially has a pro-inflammatory response. I'm not sure if any of you have had a PRP injection, but I tell all patients after a PRP injection, there's going to be increased pain, swelling, tightness in the joint or tendon wherever we inject it for about 2 to 3 days. Is pretty typical. I have had PRP in my joint, and I had that typical response where it gets kind of tight and sore, achy, and swollen. Whereas in platelet lysate, we don't see that flare typically. And we've tested that actually in myself and our office manager, where when we were testing this protocol, I had the platelet lysate injected into my knee, and definitely different than a regular PRP injection. It was like 0 flare. I was very surprised. I just had a little soreness from the injection site. And same thing with our office manager. She confirmed that there was really no flare that she had typically gotten before with a PRP injection. So much more of an anti-inflammatory effect initially with less flare with the injection. Second advantage is that we're injecting growth factors directly to the target tissue. So you're getting immediate delivery of growth factors to the target tissue with platelet lysate. Whereas in PRP, we're injecting the platelets, and then those platelets start to activate and release the growth factors over time. So in certain scenarios, there may be an advantage to getting the growth factors delivered directly to the tissue versus injecting platelets and then allowing time to let those platelets activate and release the growth factors. And then third, with platelet lysate, because we're not injecting any platelets, there's really no risk of platelet aggregation and clot formation. Whereas when you inject the PRP, you're injecting the platelets, and when they hit the tissues, they can start to aggregate and form a clot and start releasing the growth factors. And certain scenarios that may be advantageous if you're injecting into a disc or into a tendon or ligament tear, it's nice to have the platelets start to activate and kind of seal up the tears. Whereas in a platelet lysate, that may be more advantageous in an area such as the spine, where we don't want any clot formation if we're injecting into a tight spinal canal with spinal stenosis. That theoretic risk of forming, having some aggregation or clot formation isn't really desired in that setting. Now, this is a table from Dr. Ben Rawson. He did some of the preliminary work clinically as well as in the lab with platelet lysate. He's a regenerative medicine physician out of Michigan. So he looked at the different growth factors derived from platelets and quantified the concentration of these growth factors in PRP versus in platelet lysate. And the column on the right, the far right, is the concentration of growth factors in platelet lysate. And you can see there's anywhere from 6 up to greater than 30 times the number of growth factors in the platelet lysate compared to PRP. One of these growth factors of particular interest is this IL-1 receptor antagonist, which is interleukin-1 receptor antagonist, or also known as IRAP. IRAP is a very potent anti-inflammatory protein, and it's found to be greater than 6 times higher in platelet lysate compared to PRP. And this may be why that you have that little stronger anti-inflammatory effect with platelet lysate versus PRP. So where are the potential clinical uses of platelet lysate? Where do we want to use platelet lysate versus doing just regular PRP? I think the most intriguing is using it in the spine, in the epidural space. So when we're injecting, around a disc herniation and a pinched nerve, so we're injecting into the epidural space, I feel that platelet lysate is definitely more advantageous than using PRP. Now, we know based on those previous studies I discussed that PRP is effective for lumbar disc herniation and radiculopathy, and it can be, the studies are showing that it's equal or possibly better than a steroid. Now, I think platelet lysate may even have more of an advantage compared to PRP. One, because of the more immediate anti-inflammatory effect. So these patients with a disc herniation that's pinching a nerve are in a lot of pain. They have nerve pain, and I'm always hesitant in a patient with a lot of pain to inject any PRP there because that's going to inflame it more initially. Now, the second advantage is that you're getting with platelet lysate, you're getting that immediate delivery of the growth factors versus the slow release. Now, if you're injecting into a joint, that slow release is fine because the platelets are going to stay there and all the growth factors are going to get to the targeted area. But in an epidural space, when you inject those platelets, they may not stay there. It's going to migrate up and down above and below the target area. So by the time those platelets start to activate and release of growth factors, they may be far away from the area that you're targeting. So maybe you're not getting the effects that you want from the PRP versus injecting the platelet lysate. You're putting the growth factors directly into the area you need it. And then the third is, as we talked about before, the safety factor. Really with platelet lysate, no risk of aggregation of those platelets or clot formation. So definitely in the spinal canal, we don't want any aggregation to be occurring. So that's where a platelet lysate from a safety standpoint, I would say is more advantageous. Now, I've never seen any reports of patients getting a PRP injection and getting clot and having complications like that, but it's a theoretic risk. And you want to, for safety reasons, I pretty much adopted using platelet lysate anytime I'm injecting into the epidural space around the nerves. Some other scenarios where I think platelet lysate has a role and potential to potentially replace PRP in certain scenarios. One is if you're treating a very hot, inflamed joint, someone in a lot of pain, or a tendon that's very painful. I'm always hesitant to inject PRP if they're in a lot of pain, just because we're going to inflame it more. So that's where platelet lysate may be more advantageous because of that anti-inflammatory effect. Patients with adhesive capsulitis or frozen shoulder, especially in that inflammatory phase, that PRP can accelerate that inflammatory phase initially. And I think platelet lysate definitely could be better than PRP in this scenario. We just need more studies to confirm that. around nerve. So if we're injecting carpal tunnel syndrome, carpal tunnel around the median nerve and the carpal tunnel, I think platelet lysate could be an advantage because of the anti-inflammatory effects, as well as getting the growth factors directly there. For muscle tears, I think it has a potential role. Muscle tears, we actually don't like injecting PRP into a muscle because there have been cases of heterotopic ossification or calcification in the muscle. So in muscles, we favor, I've been using platelet plasma, or the PPP, because it still has growth factors, and you're not going to have that risk of calcification. So I think platelet lysate could be even a better treatment for these muscle tears. And then lastly, these patients on antiplatelet medications or blood thinners, normally when someone's having a PRP injection, we have the patient stop that antiplatelet medication, aspirin, Plavix, a week before and a week after, so it doesn't affect the platelets that we're injecting with the PRP treatment. But that may not be safe for a lot of these patients from a cardiovascular standpoint to stop aspirin for 2 weeks if they have a history of heart attack or stroke or a stent. So with platelet lysate, they don't have to stop their blood thinners because we're not injecting any platelets. So we've taken the platelets out of the picture. We're just injecting the growth factors. So those antiplatelet medications won't affect the treatment as it potentially could with PRP. If the patients stay on the antiplatelet medication when they get PRP, it may decrease the efficacy of the treatment potentially. So platelet lysate would be a good option in that scenario. Dr. Rogers, any other potential areas where you think it could be more useful than PRP?
No, I think you've really summarized a complicated subject very well. The issue with platelet lysate, of course, is that it has not been around as long as PRP. I mean, it's been around for a while. It's not that it's brand new, but we don't have the body of literature yet. I don't know if you're going to review some of the literature, but quite the body of literature that we have with the PRP world. So I think our creative friends around the world will come up with new indications and demonstrate efficacy in those studies.
Yeah. Yep. So as you said, platelet lysate's been around, but it's definitely not as popular as PRP. So why is that? Why, everyone's heard of PRP, but most patients and a lot of doctors haven't heard of platelet lysate. So a couple of reasons for that. So historically, platelet lysate has been used in a lab setting as a culture medium to help grow cells. But in a clinical setting, it's difficult to produce platelet lysate. You need a lab. You need to do it in a laboratory type setting. So it's hard to, you don't go to the orthopedic office and they can produce platelet lysate. There's really no commercial kits or systems, machines that you can buy and then just start doing platelet lysate. It's not like PRP where there are 50 different systems and centrifuges. There are sales reps coming to the door trying to sell their PRP systems. So that's not the case with platelet lysate. And the extra processing time is an issue. A lot of docs, the PRP already takes about a half an hour to make, and then platelet lysate is an additional time to produce the lysate. So it's more time and can disrupt office flow. Some of these earlier platelet lysate preparations actually took more than 24 hours or longer to produce. So it would be a patient would come in, get their blood drawn, and they produce a platelet lysate overnight, and the patient would come back the next day. And that's not really compliant with the FDA guidelines saying that we have to do it all in one day. So that extra processing time doesn't really work with, I think a lot of docs would just rather do PRP versus taking the time to do the platelet lysate. And then lastly, there's really no set protocol for producing platelet lysate. When I was researching, I've been interested in doing platelet lysate for a while, but it was really difficult to find the protocol to do. There's no rep that tells you how to do it. We were looking into the ultrasonic method, and we could buy the machine, but the rep didn't know how to tell us how to make platelet lysate. So I had to really dig deep into the literature, did the research. We talked to a PhD to really come up with all the different methods. We chose a freeze-thaw method. And again, even with the freeze-thaw method, there are different freeze temperatures, different times. And I just kind of picked through the literature and try to come up with the way to get the most optimal concentration of growth factors in the most efficient, quickest amount of time. And I think we've done that. We can produce a platelet lysate in about half an hour, and we're confirming greater than 99% cell lysis with our freeze-thaw protocol. So very intriguing platelet lysate. So, and lots of potential uses, but what does the evidence say? What does the literature say? So I'm going to go over some of the current literature on platelet lysate. This is one of the earliest studies published in 2015. This looked at 48 patients with mild arthritis, grade 1 to 2 knee osteoarthritis. It was just a prospective trial, so no control group or comparison group. But these patients received 3 platelet lysate injections using the freeze-thaw method every 3 weeks, and the patients saw significant improvement in all outcome measures at 32 weeks as well as 52 weeks. Here's another study from 2016. Looking at platelet lysate for use in lateral epicondylitis or tennis elbow. This was 56 patients with refractory lateral epicondylitis, had 3 platelet lysate injections weekly, again using the freeze-thaw method. And these patients also saw significant improved pain and function at 1 month, 6 months, and 12 months post-treatment. So similar data to what we're seeing with PRP. Now, this was some case reports published by Ben Rawson in 2020. He used platelet lysate to treat large lumbar disc herniations with radiculopathy. He would inject the platelet lysate epidural around the disc herniation and pinched nerve, and then he would inject PRP to the facet joints and the ligaments at that same segment to help stabilize that segment. And he saw significant resorption of disc herniations and resolution of symptoms. So I'll go over some of the cases he presented. Now, he's done hundreds of cases. These are just 2 of the cases that he published. So his first patient he discussed was a 31-year-old with 1 year of left leg pain, numbness, tingling, had failed medications, had failed epidural steroid injections, and surgery was recommended. So this patient had a first platelet lysate injection and had about 50% relief after 4 weeks, then underwent a second injection, and after 4 weeks after the second injection had almost complete pain relief, and there was significant resorption of the disc herniation on follow-up MRI. You can see on the top picture that large disc herniation going into the spinal canal, pinching on the nerves, and then 4 weeks after that second platelet lysate injection, significant resorption of the disc herniation. Now, we do see naturally that these herniations can resorb over time with the body's natural healing process. Now, this patient had been symptomatic for a year, and with the before and after MRIs, it definitely seems like the platelet lysate may have helped that healing along. It makes sense that with the platelet lysate, we're injecting growth factors, the healing factors to hopefully help heal that disc herniation faster. We just need more head-to-head studies to prove that's the case. But these are pretty compelling before and after pictures. His second patient he presented was a 38-year-old with left leg pain and numbness for 4 months. Persistent symptoms despite medications and 2 epidural steroid injections. This patient underwent 2 platelet lysate injections about 2 months apart, had complete resolution of symptoms and near complete resolution of the disc herniation 3 months after that second platelet lysate injection. You can see the top picture, that large disc herniation, and then after 3 months after that second injection, almost completely gone. And then Centeno published a case series of a larger number of patients, 470 patients that underwent platelet lysate injection, again for lumbar radicular pain. 58% of the patients had 1 injection, 18% had 2, and 11% had 3 injections. And he showed that greater than 72% of the patients reported feeling better at all time points from 1 month up to 24-month follow-up. Majority of the patients had improvement in pain and function at 1 month and had to sustain that improvement at 2 years. Only 2.3% of this group of patients eventually went to surgery. This was another study looking at knee osteoarthritis, so 58 patients, randomized controlled trial, moderate grade 2 to 3 knee osteoarthritis. Half the patients received activated PRP injections and half received hyaluronic acid injections. Now, This study was technically not truly platelet lysate. This PRP was activated with calcium gluconate. So the PRP was mixed with the calcium gluconate to start activating the platelets and then start releasing the growth factors. So that's technically called, we call that platelet releasate, not platelet lysate. So the platelets aren't actually lysed, it's just they're activated, so they start releasing the growth factors before the injection. But this was an interesting study because in this study, the primary outcome was actually changes on MRI. They were looking at improvement on MRI findings in the arthritic joint, not just pain and function like most studies will look at. So the primary outcome measure was the portion of patients that had at least a grade 1 improvement on MRI at 6 months after the treatment. And this was done by a blinded radiologist. So the radiologist looking at these images didn't know if the patient had the platelet activated PRP or the hyaluronic acid. And this study showed that 48.3% of the patients in the activated PRP group versus only 8% in the hyaluronic acid group had at least a grade 1 improvement on repeat MRI at 6 months. Now, these patients also improved with pain and function, but the primary outcome measure was looking at the improvement on MRI. And that's a pretty significant finding that you're seeing actually improvement in the cartilage status on follow-up MRI in that time frame. So these authors concluded that activated PRP reduces articular damage as evident on MRI as soon as 6 months post-treatment.
Was that do you know how they scored the MRI in this study? Do you recall?
I didn't see any details about how they scored the MRI. I believe it was just the radiologist reading and giving their opinion on the cartilage grade, grade 1, grade 2, grade 3, grade 4. So
okay.
And this final study was actually a comparison of platelet lysate versus PRP for knee arthritis. This one had 25 patients with bilateral knee arthritis, a moderate grade, grade 2 to 3, and they injected one knee with PRP and the other knee with platelet lysate in all these patients with bilateral knee arthritis. Each patient had 3 injections, 21 days apart. And they found that both groups had significant improvement in pain, range of motion, and WOMAC score at 1 month, and they were even better at 6 months. Now, at the 6-month follow-up, the knees injected with platelet lysate were found to be statistically better in all outcome measures compared to the knees injected with PRP, which is very interesting. So this is a study actually showing that maybe platelet lysate could be better than PRP for knee arthritis. I don't think we're there yet, but, interesting evidence that it could be. It sounds like it's at least as good, maybe better than PRP.
And not just in the short run, but in the long run.
Yeah. And then we're tracking data. So we use this data biologics registry to track data. That's a national registry. So we actually pulled the data from patients around the nation that have had platelet lysate for various indications, 154 patients, just to kind of look at their pain scores. And this graph in the middle here is the pain rating. So you can see there's a significant improvement in pain going from about a 6 down to a little over a 3 in 3 months. Most of these patients had reached MCID, which is minimally clinically important difference. So it's meaning a meaningful improvement at the 1 month mark, and had stayed at that MCID, better than MCID, up to 2 years. So very important to track our data so we know, how well the treatments are working, and data biologics.
And it'll also help us identify the new indications that you were asking about earlier. As doctors experiment, it's one thing to get data from a published paper, but anyone who's published research knows it takes 3 to 4 years from the start of the study till when the data actually gets published. Whereas with real world registry, you can see what your colleagues are doing, in just a few weeks, few months.
Yeah. Great to have data, real world data. So in summary, platelet lysate is an exciting and emerging treatment, which has potential advantages over PRP in certain clinical scenarios. So definitely certain areas where I think platelet lysate has a promising role. I definitely think it's a promising alternative to epidural steroid injections for treatment of disc herniations. We know data is showing that PRP can be effective for disc herniations with radiculopathy, and I think platelet lysate could even be better. We just need more data. I'm even interested in possibly doing a head-to-head trial of using platelet lysate versus steroid for an acute lumbar disc herniation and see, what is really better. I think that would be a great study. And early data suggests that platelet lysate may be as good or possibly better, as we saw in that last study, than PRP, but we just need more data to, see how everything pans out. But definitely a great treatment that I'm really excited about. We've been using it a lot. Dr. Hombach's been using it a lot. And I think it's a great addition to our toolbox.
Especially in the context that in the case of, first of all, thank you. That was great. A great summary. Thank you. I learned a lot. We see, herniated disc, extremely common, sciatica, leg pain, back pain, one of the #1 causes of disability in the United States. Physical therapy and epidural steroid injections are the mainstay of treatment, have been since Ed and I were just little kids. We weaned our teeth on injection therapy on the epidural steroid, back in the late 80s, early 90s, when that started to become a new tool in our toolbox. And so we were very excited to have epidural steroid injections, and obviously there's a benefit to them. There's some downsides to them, just as in any medical treatment. There's some risks. Our patients who are diabetic, it does tend to bump up their serum glucose levels. There may be an association with osteopenia, osteoporosis. I think our more informed patients just really don't like the idea of having steroids injected in their bodies, because they're aware that although it's effective for pain relief, it may not have the regenerative effect that some of these newer treatments have. Of course, there's the burden on us. The scientists and the physicians need to do the studies to demonstrate that platelet lysate, PRP, are not inferior to epidural steroid injections. And that's how we get to a new standard of care. And then, of course, we need to train physicians how to properly make platelet lysate in their offices, and then provide it to their patients for proper indications. But really encouraging early data for this technique. Also, we didn't talk about it, but the safety is very high as well. So it's the same, we're injecting. So this is the same risk as an epidural steroid injection. You have the risk of bruising, bleeding, infection, which are all very low, but are occasionally can occur. But we don't see any increased risk, any increased adverse events with the use of platelet lysate in these indications. So really encouraging early data coming out of literature.
Yeah, I'm excited. I think that platelet lysate definitely has the potential to heal that herniated disc faster than just steroids. It makes sense that you're putting healing factors into the area to try to accelerate that healing and resorption of the herniated disc. And just waiting to see how the data pans out. And but I think it's a great option, especially if some patients can't have steroids, can't have steroid injections because of side effects and other medical conditions. And then some patients fail the steroids. And then that's where, we don't typically do that series of 3 anymore. We do one. You can definitely, I think it's reasonable to try one. If it doesn't help or gives very short-term benefit, I think platelet lysate is a good next option.
Yeah, it's only a matter of time, and more studies need to be produced before we realize that it's worthy of being a first-line treatment.
Yeah.
But I think it's judicious to be conservative whenever you have a new technology, and just follow the evidence. It's really interesting. I don't want to nerd out too much, but the whole concept of resolution of a disc extrusion or sequestration is interesting. The biology has been well described in the literature. Thought to be mostly due to the inflammatory cells, so the macrophages, monocytes, neutrophils acting on that disc tissue. But we're not injecting those cells when we do platelet lysate or even leukocyte-reduced PRP. So it looks like the mechanism of action for resolving those disc herniations is perhaps different than we originally thought.
Interesting, yeah.
Okay, we got some questions here. So again, thank you, Dr. Evangelista. That was really
Oh,
fantastic. Go ahead. Oh, sorry, I thought you had a question. So
no.
right off the bat, first question, something that we did not talk about, but compression fractures. So we know that compression fractures are extremely common, particularly in postmenopausal women who may have osteopenia, osteoporosis. This is a huge problem. Typically, the management is conservative with physical therapy, bracing. In severe cases, and rarely are surgical procedures necessary, although it can happen if there's significant compression of nerve tissue. But the question is, might platelet lysate be helpful in the healing of bone? I'm not aware of any data. Are you?
No, I haven't seen anything that shows that platelet lysate could be used in that setting. So I would say no.
It's an interesting question because there's another medical indication where there's impaired bone function, imbalance between bone regeneration and bone catabolism, and that's in chronic osteoarthritis, where you can have altered physiology of the bone, not just the cartilage, but the bone underneath the cartilage, something called the subchondral bone. And this is evident on MRI. You can see increased signal on the MRI. We also see it in the spine, by the way, in the vertebra with disc degeneration. But there are some studies that show that if you inject PRP directly into that bone, that you can positively impact the healing of the bone. Not in this conversation but relevant to the question is the use of electromagnetic therapy. Anyone wants to do a deep dive into the literature can read about the effects of pulsed electromagnetic fields on non-unions, stress fractures, even osteopenia. So you might want to look into that possibly. What's the difference between platelet lysate and stem cell banking for future treatment? So as many of you are aware, we do have a program now where patients can bank their own stem cells. This is not a talk specifically on stem cells. We will have that presentation later, but as you know, a stem cell is also part of the healing mechanism. If you want to think of systems in your body, there is a healing system for which platelets are definitely in that system. Stem cells are in that system. All the growth factors, cytokines, exosomes, molecules that are secreted by those cells are in that system. So stem cell, something we've known around about since really since the 50s, different kind of stem cell used for bone marrow transplant in patients with cancer, but then specifically the mesenchymal stem cell discovered in the 90s, useful for regenerating cartilage, tendon, ligament, bone, and muscle. Now we have the ability to collect these cells, which live in the fat, as well as other areas in your body, but through a simple liposuction procedure, we can collect fat and then have that fat processed in the lab and then manufacture, or we say manufacture, but essentially we're growing stem cells in the lab and then bottling them as your own, first aid kit, your own pharmacy kit. These cells have the ability to regenerate tissue. They have the ability to modulate inflammation, many other properties that these cells have that will serve very strong medicinal function going forward. So the key difference between a stem cell and a platelet lysate is, as Dr. Evangelista said, is completely acellular. There are no cells in the platelet. Lysate is simply what we call the secretome. It's the molecules that are secreted by the platelets. And this is how these cells are thought to function, is through their secretions. The difference is that stem cell is a living, breathing, thinking little, I like to call them little nanobots. So you place a stem cell into an environment like an osteoarthritic knee joint, and it will sense whether or not it should release this molecule or that molecule. So it's a very interactive, dynamic process. Platelet lysate is more passive.
All right. Do you use patients' platelets to produce platelet lysate? Yes. everything's what we call autologous. So we're using your own blood and your own platelets for platelet lysate.
It is possible to, and there's been a few studies, it is possible to obtain blood from a donor, from a blood bank, for example, that's been screened for various diseases, and then manufacture PRP or platelet lysate and freeze dry it. And that's something that our company is investigating. But there's a lot more research that needs to be done in that field. And then there's questions about whether or not the FDA requires an approval to do that treatment, or if that's something that they're going to permit physicians to do now. So we're investigating that.
And how does it compare cost-wise to PRP? Basically, we're just adding 20% to the cost of the PRP, just because of the extra processing time and so forth. So 20% extra on top of the PRP.
Yep, which is why it's important for us to collect data, because our primary goal is to provide cost effectiveness. That is, we're providing the treatment, it's the right treatment for the indication that you have, and it's at the least cost to the patient. So that's where the data helps us. Some people need surgery, right? That's a more expensive therapy, but they need it. It is cost effective, whereas most patients with mild arthritis, moderate arthritis, ligament, tendon injuries, disc injuries, non-surgical care with orthobiologics is the cost-effective alternative.
Has there been any testing in the area of neuropathy? Not that I'm aware of. Haven't seen any studies using platelet lysate for neuropathy. Dr. Rogers?
Neuropathy is a huge category. It's kind of like saying back pain, right? There's a million different reasons why your back may hurt. There's a million different reasons, not a million. There's probably 2,000 different reasons why a person may have neuropathy. The most common, of course, is diabetic peripheral neuropathy, where the constant elevated serum glucose is toxic to the nerve tissue, and therefore patients will develop symptoms related to nerve dysfunction, whether it's numbness, tingling, burning pain, loss of muscle function, things like this. But there have been some preclinical studies on animals in the platelet-rich plasma world and stem cell world showing a benefit to regenerating nerve tissue, but we really don't have the translated studies to human applications just yet. So, we're in the it makes sense phase. We understand the mechanism of how platelets function in the context of nerve damage setting, but that has not yet translated into a standard treatment protocol.
Okay. Do you recommend 3 platelet lysate treatments at 3-week intervals, or single treatment and C? I definitely favor, right now, at least a single treatment and C, because hopefully it could be one and done. I think a lot of the studies that you saw were a series of 3. I think a lot of the studies were out of Europe. Europe tends to do, at least for PRP, they tend to do a series of 3 shots versus 1. There is some data that suggests that could be better, but definitely debatable and controversial. I think a lot of the places in Europe, their PRP is weaker, lower dose PRP, smaller blood draw. And that's also what I was seeing with all these studies on platelet lysate. The blood draw was tended to be a lower blood draw, like 20, 30, 40 cc's versus a 60 cc blood draw. So it's possible that because you're not getting as many platelets, you're not getting as many growth factors. So maybe it would take 3 versus 1, but we don't have any data to say 3 is better than 1. So my recommendation would be just doing 1 and see, and you can repeat it if 1 doesn't get you to where you want to be.
Yeah, from our experience in the PRP experience for the last 15 years, with the data that we've collected, 90% of our patients is 1 treatment is enough to gain significant results for out to 2 years. We expect the same with platelet lysate, but as Dr. Evangelista was saying, the devil's in the details, right? So dose becomes relevant. And in this case, dose would be the amount of growth factors and probably the spectrum of growth factors that are in the platelet lysate product. We do not have an easy way of measuring this in the clinic. It's, it's done in it's done in, basic science studies where they can measure, how many picograms of interleukin-1 receptor antagonists are you producing, but we cannot measure that yet in the lab. So, in the clinic. So the proxy for that is the number of platelets, making the assumption that if you have more platelets, then therefore you have more of these growth factors, cytokines, exosomes, all the other molecules that are secreted by the platelets. Not only that, but the size of the platelet does seem to matter. So there's some good data showing that a nice big plump platelet is probably going to have more growth factors in it than a little scrawny platelet. And that we can measure in the clinic as well. So currently we're just trying to maximize the number of platelets, maximize the number of high quality platelets, and then assuming that that translates to higher doses of growth factors so that we can see better outcomes. One other comment I'd like to make is that I'd always assumed that one very well done PRP injection, and let's just say knee osteoarthritis. So we're going to inject 10 billion platelets into that patient's knee. That's a very well done, high quality PRP, what we call a grade A PRP, would be equivalent to 3 inferior PRP injections. It's not the case. The data is showing that actually 3 inferior PRP injections is not effective at all. So there's a threshold by which you have to have a sufficient dose of platelets and growth factors to get any clinical benefit whatsoever.
Right. Are there studies with platelet lysate using it on ligaments, particularly the SI joint, sacroiliac joint ligaments? Haven't seen any studies using platelet lysate for ligaments. Actually, everything I presented was the majority of the data out there on platelet lysate right now. So not that much. We need more data. But for ligament, I would still favor using just regular PRP. The only advantage that I'm seeing right now, based on my research, is it would just give you less of a flare by doing the platelet lysate. But for ligament, I would favor regular PRP over platelet lysate.
And briefly, I'll share my clinical experience. So interestingly, patients who have sacroiliac joint, so for those who don't know, the sacroiliac joint is that joint in your pelvis. It's where your sacrum and your iliac bones come together. It's what holds your pelvis together. And there are multiple ligaments. There's at least 4 or 5 different ligaments that can become injured. If a patient's in a car accident, if they fall, slip on the ice and land on their bottom, this can damage and tear the ligament. Patients usually know they have a sacroiliac joint injury because the MRI of their spine looks really good, and yet they have pain in their low back with lifting and bending often, but it can be simply just turning in bed is an issue. They may see a physical therapist or a chiropractor who mobilizes the joint and realigns the bones a little bit, and they'll get symptomatic relief for a short period of time, but then because the ligaments aren't holding the bones together properly and the muscles aren't functioning properly, they need to constantly get this manipulation of the joint. So these patients do very well with platelet-rich plasma injection to the ligaments. Sometimes we can see the tears in the ligaments on ultrasound. Typically, you do not see it on MRI. But I find that a lot of these patients get what I call a honeymoon period. So they have these deficient ligaments that aren't strong and taut, and you inject fluid into them, it kind of stiffens them up a little bit for maybe a week. And patients will actually get better during that time period. Of course, the body absorbs the fluid, the ligament's not yet regenerated, so then they got to go through the rehab process, and the PRP has to kick in, and you have to grow more fibers, and then till you have a strong ligament. But is that something you've seen as well, Ed? That's something I've seen many times.
I haven't seen that too much. Yeah. Yes,
Okay.
SI joint's very complicated because you got the joint, you got the ligaments, you got instability, you can have pain from the instability, pain from the injured ligaments, pain from the joint. So that's a complex issue.
It is, and difficult to diagnose sometimes. All right, what other questions?
Okay, we talked about peripheral neuropathy already. Is the return to normal activity quicker with lysate as opposed to PRP? I wouldn't say that necessarily. I would say that the flare is definitely less. So that first couple of days, you might be better, quicker, just because there's no flare or less flare than with PRP. But if we're treating a tendon or a joint, you still want healing to take place. So the restrictions will be similar. I wouldn't say there's faster return to normal activity, except for that first few days would be faster.
I mean, most patients are able to return to activity pretty quickly.
Yeah.
Depends on the underlying condition, but if it's a more mild condition, I don't find that my patients are out for more than 3 to 5 days. Let's see, what's this? Here's one for you, Ed. You did PRP on this person's neck.
Okay. Second round, yeah, second round might bring additional improvement. So I would want to do a follow-up to kind of assess what the response was. Do we need a second one in the same area or a different area that needs to be treated? So definitely needs a clinical follow-up on that one. And then lumbar, happy to take a look at that. I'm definitely doing a lot of lumbar spine as well. And the cost for this versus a stem cell program, I'm not the one to answer that one. I'll send you over to Andrea, who can answer all those questions about the cost of stem cell program and all that.
Yeah, this is a case where it's very patient specific. Depends on what the patient's individual needs are. So the treatment plan will be dictated based on the needs of the person, and it can vary. In general, stem cell therapies cost more than PRP and platelet lysate therapies. In some cases, we can't even offer stem cell therapy based on current FDA regulations, but there are, again, for another lecture, there are some interesting early access programs that are available to patients in very specific conditions. So that's somewhere you want to talk to one of us.
Okay. So as opposed to prolotherapy and standard PRP, which produce an inflammatory response, don't they encourage a follow-on cascade of platelets that you don't get with lysates? So I think that with prolotherapy and PRP, you are producing that initial inflammatory response and initiating that healing response, which does have inflammation on the initial phases, and then that healing cascade takes place. With platelet lysate, yeah, you're not getting that immediate flare, but we're putting the growth factor directly to the area to start that healing process initially. So maybe it doesn't need that inflammation per se, because the inflammation is getting those attracting to the growth factors and cells and different molecules to the area to start healing in that inflammatory phase. But with the lysate, because we're putting the growth factors directly there already, maybe you don't need that inflammation per se. I think that's what you're asking.
Yeah, it depends on the biology that we're dealing with. So many of the conditions that we treat are what I would call failed healings or stalled healing. The beautiful thing about the human body is it can heal itself. Thankfully, most of the things that ever happened to you in your life, you didn't have to pay one of us to treat you because it just healed on its own. That's what the body does. It's a natural system that when functioning properly will heal you. The problem is there are certain areas of the body that are harder to heal than others, or there may be coexisting medical conditions that impair healing. So for example, cartilage does not heal very easily. Discs do not heal very easily. Ligaments, tendons do not heal very easily. They take time. They don't have the cellular firepower that your muscle or your bone may have. Or there may be a coexisting medical condition. A patient may be diabetic. This impairs their microcirculation. And so if they get a cut or an ulcer on their foot where there's poor circulation, they may not be able to get the platelets and the stem cells down to the injured skin, and it doesn't heal well. So you need a little help from us. So the thing to understand is that most of the cases of chronic pain are low-grade inflammation around tissues that have failed to completely heal. And whether we're using platelets or stem cell therapy, platelet lysate, we're just trying to jumpstart that healing process. By the way, exercise does this too, right? You stimulate the tissue, it invokes an inflammatory response. What is inflammation? You're attracting immune cells to clear out the debris, to make room for new tissue growth. And the inflammatory cells are sending out a signal to attract stem cells to the site to help with that repair process. So we need inflammation. It is part of the healing process. What you don't want is your inflammation to go beyond 2-3 weeks. You want it to, run its course and be done. And so, whether we stick a needle in there, whether we inject prolotherapy, which is dextrose sugar water, causes cells to pop, creates this inflammatory reaction, whether it's platelets that are injecting growth factors, platelet lysate, which attracts stem cells to the site. I mean, there's a biologic cascade that's almost impossible to measure in a patient, but has been studied in animal studies and in the lab. So inflammation is a part of healing, and all these treatments jumpstart that healing process.
Okay. All right, we'll try to run through hopefully the rest of these questions. We have up 4 more minutes. Platelet lysate can treatment, collection, and treatment on the same day. Yes, everything's done the same day. It just adds an extra half an hour, 45 minutes to the treatment. So you're sitting around a little longer. Is there an age limit? Someone 71, whiplash, no age limit. Definitely with platelets, doesn't really affect the treatment at all.
I'll just share with you, you all know people who are in their 80s who can outrun you, and you all know, 50-year-olds who can barely get out of the chair. So it's not so much how many years you've been on the planet, it's how well you've taken care and how lucky you've been along the way. And then if you're presenting with a certain medical condition, how severe is that condition? So it takes longer for a condition that's been there for many years and is very severe, and then a condition that's maybe been there for a shorter period of time in a person who otherwise is very healthy.
Okay, any progress with PRP getting covered by health insurance, Medicare? Well, I had hopes. There was TRICARE that was paying for PRP for active military for knee arthritis and tennis elbow, because those are the conditions that we have the most robust data. But as of October 1st, we just heard that they're not going to cover it anymore. So it's going in the wrong direction. I haven't seen any other insurance companies that are willing to pay, even, if they analyze the data, I think it would be cost effective for them to avoid knee replacements and arthroscopies with one PRP injection.
We have that data.
Really,
we have data that shows that PRP in the hip, PRP in the knee does delay the need, in some cases completely obliviate the need for joint replacement. The issue is that if there are 400 clinics in the United States offering PRP, there's 400 different ways to offer PRP, and the insurance company has no way of mitigating their risk because they don't understand what they're getting for their money. So I think that's the key issue. It's not that the science isn't there. It isn't that it doesn't make sense. It's just, I think they can't predict what a given clinic will offer. And I think once we standardize the doses, standardize the protocols, standardize, who gets it, who would not get it, I think that's how we move things forward.
okay.
We're working.
Would you recommend platelet lysate for osteoarthritis of the lumbar spine? Possibly. I'm still using PRP as my go-to for facet joint arthritis in the spine and the ligaments. In the epidural space, definitely using platelet lysate, but for the facet joint arthritis itself, I would still favor using PRP, but still open to platelet lysate. Again, we don't have enough data to say it's better yet, so stick with the tried and true initially, unless it's failed and we want to do platelet lysate for some reason.
We get new data every week, every month. So all it takes is one good study to show, hey, we looked at 300 patients and we showed that this was superior than the alternative. That's the beauty of science. It's always changing and people don't like it, but it is always changing and it's always hopefully improving. And, we'll try to bring you the latest and greatest so we can provide the quickest solution to get pain relief and return people back to the things they love to do.
I did treat a patient actually for a very inflamed facet joint arthritis with facet joint synovial cyst who had tried PRP a few years ago, didn't have great results. So in her, we tried the platelet lysate. Wasn't anything surgical, but didn't want to do the typical nerve blocks and burning the nerves and all that. So I'm hopeful that it will help. We just need to, those patients have to, fill out the surveys and let us know how they're doing so we can, track these patients, see if it's working. So that's important.
Yeah, we just looked at our data. So I think we have now 4,000 patients just from our clinic in the database. And we asked people 12 months if they're satisfied with the treatment. So if you look at everything head to toe, neck, back, shoulder, hip, knee, we're about 91% satisfaction at 12 months. That means we're failing 9% of our patients. So we need to continue to push the science forward, push our protocols, develop new ways to, figure out how to help that 9%. They may need more treatments. They may need additional treatments. They may just need surgery. But that's why we track the data.
Yep. All righty. I think we're out of time. Thanks everyone for joining. Thanks for all your questions. Make an appointment if you're interested in pursuing possible treatments, and we'll let you know if you're a candidate, if we recommend platelet lysate or PRP or the other lots of different orthobiologic treatments that we have to offer. So
thank you, everybody. We'll see you next month.
okay, bye-bye.
Bye.